Sir, our Central IAP President 2024, and he had Professor of Pediatrics, Indira Gandhi Institute of Child Health and Bangalore, IAP National President elect 2023, and IAP National Honorary Secretary General 2021, National Chairperson Intensive Care Chapter 2020, Founder Secretary of IAP. ID Chapter Karnataka, EB Member Central IAP 2014 and 2018, Convener Pedicon Scientific Committee 2017 and 2018, National Scientific Convener IAP Action Plan 2018-2019, and resource person and recipient of Dr. Y.C. Mathur Oration 2019 Twin Cities Branch, and recipient of O. Ganesh Memorial Oration, Nirmal Kesari Endowment Lecture, and he had done Pedicon 20 Oration in Telangana 2021. Central Zone in Telugu Pedicon Oration Lecture was given. Gopal Chandra Das Memorial Oration Lecture, Anandas Handilia Memorial Oration, M.R. Shinoy, and Pardasarthi Memorial Oration, Mallesh Memorial Oration Lecture, Bangalore, and recipient of FIP in 2017, recipient of BC Roy Award in 2020, and IMA Karnataka. Publication he had in his name and book chapters around more than 100, and on editorial board, Journal Pediatric Infectious Diseases, Journal Pediatric Critical Care, and Indian Pediatrics. These are all the things, and many more are there, but short of time, we will go directly for the oration. Sir, please welcome, sir.
Let me move on to the topic. This is the institute where I am heading the pediatric intensive care unit for more than 2 decades. Today, what I am going to talk about in the next 30 minutes about rickettsial infection. The moment we talk about rickettsial infection, as an undergraduate, we all read about rickettsial infection in microbiology. We did not see any cases of any rickettsial infection as an undergraduate. After that, when I was doing my post-graduation, I never, at least in undergraduation, I read about rickettsial infection. In a post-graduation, so almost it was unknown entity in the way back in 1998. That's the year where I did my MD Pediatrics. So it was an unknown entity. After completing my PG, I joined an Indira Gandhi Institute of Child Health. That's the time I started seeing in a few cases of here and there in a rickettsial infection. That was also time where we were thinking about, is it a meningococcemia? That was how the whole story of rickettsial infection was started, and mortalities were so high, morbidity was so high, there was no diagnosis, just we are imagining that it is in a case of a meningococcemia. Yeah, meningococcemia and all. That was the whole story. So that's the reason, just I thought what I have been experienced in the last 2 decades about the rickettsial infection, let me share about this with some of our research work too also in this. So it is a zoonotic disease, we all know that. The moment we talk about rickettsial infection, what's common in Indian context over a period of 2 decades of experience is epidemic and endemic typhus. These are the 2 things which is common. On top of that, the more common, especially in Hyderabad, Karnataka and Telangana, in this region is our scrub typhus is a very, very common thing as compared to the epidemic and endemic typhus. Rocky Mountain spotted fever, so Mediterranean spotted fever, these are all the things which is not that common in our Indian context. One of the things which is talk about in rickettsial fever is the Sushumshi triangle. This is one of the things, we look at that. So one side is occupied by India, Pakistan, Afghanistan, other side which is in Japan and Russia and Australia. This is called as in the world's Sushumshi triangle. As far as the Indian context is concerned, rickettsial fever is one of the commonest thing, even though it was previously, it was there in Maharashtra, Telangana, Andhra Pradesh and Karnataka. Now it is across the India, even Himachal Pradesh, and a lot of literature has been emerged in the last 2 decades. This is basically because of deforestation and seasonal changes and scrub vegetation, close proximity to the domestic animal and all. Just before going to the clinical things, let's understand the basic concept of pathogenesis, how the things really happens in a rickettsial infection. When we talk about rickettsial infection, trigger or tick bite, that's where the eschar formation which is going to be there. It all depends upon the type of an rickettsia and also the this one. So basically, eschar will be there as low as 7 to as high as 68%. We'll see in our context what is the things when we reflect about our studies. And the moment the trigger bites, bacterial inoculation will be there, we need to look at the local lymph nodes. Lymph node enlargement is one of the things. Apart from that, once the phagocytosis and escape of phagosomes and cytoplasmic multiplication and all which take place, reticuloendothelial cell involvement, that is basically hepatomegaly, splenomegaly, lymphadenopathy and other clinical manifestation which is because of a capillary endothelial damage where the capillary leak sets in, that's where the cytokine and almost it is a coccobacilli, acts like a gram-negative septicemia where the ARDS neurological complication which is going to be there. I'm going to share those my experience also. With this clinical background and epidemiological thing, let's come to the how the clinically this has been evolved over a period of 2 decades with our experience. This is a first case. Whenever the patient comes with an OPD, this is a 12-year-old child, female child, came from Indupur, presented with the complaints of fever for 4 days. On the 3rd day of fever, child is developed in a rashes and generalized swelling, that is more of a capillary leakage. When you clinically examine this child, there was a conjunctival congestion, which is a non-exudative type, and febrile, and the patient was anemia. There was a generalized edema and erythematous rashes all over the body, which is involving the palms and soles. You can see the one of the picture which is there, and of course hepatosplenomegaly and ascites. So fever, rash with hepatosplenomegaly, child was coming from endemic area of Indupur, which is a very, we get a lot of cases of that. So dengue and rickettsial fever is a thing. In a COVID background, we need to think about multi-system inflammatory syndrome, post-COVID syndrome, and chikungunya, sometimes it can present. Leptospira and meningococcemia is not that common in our southern part of the India. Those are the initial things. With this child has been investigated. When you look at the investigation, there is an anemia, HV is 8.2. There is a neutrophilic leukocytosis. In a case of a rickettsial infection, so usually if there is a leukocytosis, it is a more of a neutrophil is than a thing. Thrombocytopenia and hyponatremia. When you look at the electrolytes, specifically we need to look for the sodium level. Hyponatremia is one of the things. Of course, hypoalbuminemia and SGOT, SGPT was mild derangement, and all these things which is pointing towards a possibility of a rickettsial infection was the thing. So when you look at is there any specific test for the rickettsial infection? Of course, what we do it in our hospital is we do an MAC ELISA, that is our wheel pelix test by ELISA method. But majority of the time in the periphery, they do it by immunochromatographic method. It has got its own limitation, similar to that of a Widal test. If you are doing it by ELISA with a very high titer, then we can think about rickettsial infection. This is the child which is having an OXK 1:640, which is pointing towards a scrub typus. If it is a OX2 or OX19, you would have thought about endemic and epidemic typus. OXK is the one which points towards a scrub typus. So, is there any clinical and criteria where you can say diagnose a rickettsial fever? The clinical criteria which has been evolved by Rathi score that has been published in Indian Pediatrics. I'll come to that Rathi score in a moment. So in this child, we looked into the clinical Rathi score, which was 23/35, anything more than 14, which is pointing towards a rickettsial infection, along with OXK. So OXK is not a your wheel pelix is not a confirmatory test. It is suggestive of that. Immunofluorescence is a confirmatory test. We don't do it in our ICUs, in our settings. It is very difficult to get it. That's why we don't. This child was treated with the doxycycline. So with the doxycycline of 5 days, this child has completely recovered without much. This is the usual presentation. Whenever the child comes, we don't miss it. So that's the thing. So as far as the wheel pelix test is concerned, it is a less sensitive. If it is positive in eye titer, that's the time where you can take it. Ideally, we need to go for an fade sera. That's more important. Immunofluorescent assay is one of the thing, but it is not really available in clinical practice. That's why we still depends on ELISA by wheel pelix test, even though it has gotten a limited value. So take home message out of this case is early clinical suspicious is required for diagnosis of rickettsial fever. Wheel pelix test is got a limited value which needs to be used in the clinical diagnosis. So what is most important thing, if the child coming from endemic area, you are suspecting a rickettsial fever, simple therapeutic trial of a doxycycline of 3 to 4 milligram per kg, maximum of 100 milligram BD, that's then almost like acts like a diagnostic trial. Therapeutic trial. Let's move to the second case. This is a child, which is a 6-year-old child, came from Chikbalapur, adjacent districts of Bangalore, where the child presented with a fever for more than 2 weeks. There is intermittent and very high grade, no diurnal variation, and or any other associated symptom. Only fever was the only clinical. It was been extensively investigated. All the investigation turned out to be a normal thing in this. And this child, which has been on clinical examination, there was a mild pallor, liver was 2 centimeters, spleen was just palpable. There was some reticuloendothelial cell involvement was there in this case. So differential diagnosis, since it is in a fever of more than 2 weeks, we are thinking about an PUO, where the enteric fever is one of the thing. Leukemia is the one of the thing as an PUO we need to consider. Sogia is another thing. Whenever we don't find anything, our differential diagnosis always goes within a sogia. Tuberculosis, retro, and rickettsia was also one of the things which was being considered. Just fever was the only clinical manifestation in this child. So, and once again, the investigation was repeated. So, there was a neutrophilic leukocytosis along with thrombocytopenia with mild elevation of SGOT, SGPT. CRP was high. So that was the thing, and child is coming from an endemic area. That made us to think about a possibility of a rickettsial infection. Since the child was already more than 2 weeks of a fever, we did an wheel pelix test, that is OXK was 1:320. So the message what we wanted to convey out of this case is, so when we applied a Rathi score, in the Rathi score where it was fitting into the more than 14, that is anything more than 14 is pointing towards a rickettsial infection, it will not confirm, and OXK was positive. This child was treated with a doxycycline, child was recovered completely. So just a word about this Rathi score. It is basically takes 3 things into the consideration. Epidemiological things is a very important thing. Clinical symptoms is clinical signs and symptoms is the second thing. The third thing is your lab criteria. Totally the whole things which will come to the around 35. Epidemiologically, we need to look at the child is coming from rural or urban. Nowadays, it is both. Rickettsia is almost in urban also we are getting it. And take the vector, we need to look at it. Conjunctival congestion, basically skin involvement or mucus involvement or reticular endothelial cell involvement. Basically, the moment you say skin, it is a maculopapular rashes. The moment you say it is a conjunctival congestion. When we talk about reticular endothelial cell involvement, lymphadenopathy and hepatosplenomegaly. And of course, investigation-wise, leukocytosis or leukopenia, thrombocytopenia, hyponatremia, hypoalbuminemia. These are the things which is very important in this. So after that scoring, if the score is anything more than 14, that's the thing which helps us to make a clinical suspicious of this. Whenever you are the child coming from endemic area, now you can't say it is epidemic, it is almost become an endemic across the India. So we need to think about rickettsia is one of the clinical presentation of rickettsial infection is a PUO. So we need to suspect and give a trial after or investigate it, you will get a diagnosis of that. That's about the rickettsia which is presenting like a PUO. As a clinician, we need to remember these things. It is a very common thing. Let's move to the other presentation. This is an 8-year-old female child, came from Lepakshi, Andhra Pradesh, presented with a fever for 8 days. and abdominal pain for 3 days, cough for 1 day, and hurried breathing for last 1 day. Means second week of the symptoms, the child is getting a respiratory distress, and the clinical findings, there is an anemia, facial puffiness, and the child is tachypnic. Look at the saturation is 66%, and the reduced air entry bilaterally and hepatosplenomegaly. X-ray is typically suggestive of an ARDS. So that's how this child has presented. So as usual, whenever the child presents to emergency department or critical care unit, our differential thoughts will be an severe pneumonia, which is presenting like a ARDS, that's what it comes. Dengue hemorrhagic fever with the early recovery phase, that's the time where the fluid overload is likely to be there and it can present like an ARDS. That's what we think about. The third thing is an rickettsial fever with MARS is the other thing. MIS-C secondary to the COVID. These are the some of the differential thought in the present era. These are the things we think it. This child was investigated. Look at the investigation here. There is an anemia and leukopenia, and neutrophil is high, thrombocytopenia, SGOT, SGPT is right, CRP is more than 100, hypoalbuminemia. So coagulation profile is also in a disturbed. When you look at this child, so far we used to talk about was neutrophilic leukocytosis, but you need to remember it can also present with a leukopenia. Leukocytosis, leukopenia, both are things. Generally, leukopenia will be there in the early stage, whereas then a leukocytosis will be there on the later stage. If the severity of the disease is so much, what we call it as a degenerative shift in the count, where the shift to the left with the toxic granule and bad worms, that indicates that this is the child which is having a very moribund state. That's what it has happened in this child, where the immunological response is very poor in this. That's why leukopenia was an thing in this child. So we diagnosed it as a more of a OXK came positive. We diagnosed a case of an ARDS, which is because of an rickettsial infection. So, and Rathi score in this, we applied it, it came 30 out of 35, OXK was positive, and this child was treated with an doxycycline. Apart from the supportive care, this child is recovered completely with an ARDS. This is the way back, this is the child which was there, it was in 2013. Though this child has completely recovered, we shifted out of an ICU. During the shifting it to the step down, this picture was taken, child is completely recovered. This is the way back in 2013, that means almost 11 years back. We looked into our data of how the rickettsia is presenting with an ARDS. It was published in Pediatric Infectious Journal in 2013, where out of 88 cases, we analyzed the patient which has been admitted to the pediatric intensive care. Out of that, 14 patients had an ARDS. And out of that, the 71% of the ARDS is required a mechanical ventilation. That's the time where the we started using in dengue, we started using de-resuscitative measures, that is in the late recovery phase of a dengue with ARDS, where the decongestive measure, de-resuscitation, where the Lasix infusion was the thing. In these patients also we tried. So almost all the patients where we used an Lasix infusion after stabilizing the hemodynamics and intensely monitoring the hemodynamics, these are the patients was completely recovered once we started using the Lasix infusion in that. So basically what we need to do is, as a clinician, so we need to be aware, rickettsia, if you identify early, if you pick up the things early and manage it, these complications will not arise. Otherwise, you will land up with an increased morbidity and mortality in a critical care unit. And ARDS is one of the complications of a rickettsial infection. We need to be highly vigilant on that. That's the message out of this publication, what we did it in 2013. So rickettsia, if you treat it early, you will have a good outcome. That's about an ARDS presentation of an rickettsia. Let's look into another case. This is a 6-year-old child, came from Kola. Apparently child was normal, but developed a fever for 8 days and pain abdomen on the 5th day of the fever, altered sensorium, multiple episodes of convulsion, on the 8th day, just before the admission, this child is developed in a convulsion. There is a typical clue, the child developing a convulsion on 8th day, very few options. I'll come to those things. And mild failure, generalized capillary leakage was there, and the blood pressure was normal. There is a bradycardia and raised ICP, and hepatosplenomegaly was there. So as usual, whenever the child comes with less than 14 days to your emergency department, your differential diagnosis is dengue, chikungunya, JE, and rickettsial encephalitis. These are the things which comes in the mind. How do we rule it out? Dengue, majority of the time, dengue presenting with encephalitis, usually it could be caused by hypoglycemia or dyselectrolytemia. Dengue per se can present with encephalitis, but majority of the time it will be there in the first week of the illness. Chikungunya, it can be there in the first week as well as the second week also. Typically, any viral infection, which is a prodrome followed by third or fourth day, they throw a convulsion, altered sensorium, majority of the time they present. Whereas pyogenic meningitis, unless it is complicated, most of the time your convulsion will be there on third or fourth day of the illness. In this child, one of the typical thing is, in spite of this one, this child on 8th day had in multiple episodes of convulsion. That made us to think those days in 20, it is almost decade back I am talking about. Presently we don't take much time to diagnose rickettsial encephalitis. Those are the days how we came to this. So this child was being investigated, the thrombocytopenia was there, and mild elevation of enzymes and hypoalbuminemia, hyponatremia. That made us to think about a rickettsial infection with a raised CRP. And this child has been positive for the scrub typus, where we did an ELISA by IgM. And after that, we also looked into the Rathi scoring system also, 28 by 35. And this child was treated with an IV doxycycline. IV doxycycline is difficult to get it. Very few places where you can get an IV doxycycline. Yes, it is available. This child was being recovered. We published a data in 2013, where we looked into the presentation of this is a prospective observational study from 2010 to 2011. That's the time. We were published in 2013, where we looked into the presentation of this is the thing. When you look at the rickettsial encephalitis, the commonest age group which affects is 5 to 10 years. That's the time which is more likely to be affected, age group wise. And also we looked into the rashes. Rashes is, even though we say it is synonymous with that of rickettsia, but 25% of the rickettsial infection can present without a rashes. That's what our study is looked in those days also. And of course, rest of the Yeshkar, which was there only in 12%. As the review, when you look at the literature, it is in a 6.8 to 68%. That's the thing. But in our study, it was there almost around 9.8%. That means rickettsial infection can present without a rashes also. That's what we looked into these things. And of course, our anemia, thrombocytopenia, hyponatremia, hypoalbuminemia, all these things are the clinical manifestation. We have published our data. So rickettsia can present with a neurological, but remember, usually the moment we see rickettsial infection, where the vasculitis is one of the things. So usually second week, the neurological manifestation will set in. So if you treat early, so these complication is going to be less. Once again, we looked in reviewed the literature. Once again, we published one more article in the last year itself in 2023. Looking at is there any change in the clinical spectrum of rickettsial infection, especially with the neurological things is concerned, which is published in Indian Pediatrics, which is available in Indian Pediatrics. You can. So where we looked into the things, once again, almost around 27.8% of the cases of rickettsia can have a neurological. But what is more important in the present study, rickettsia can present like an acute stroke. You need to be aware, it can not necessarily, it is a acute febrile encephalopathy, it can present like a stroke, it can present like a lateral rectus sixth nerve palsy, it can present like an acute cerebellar ataxia. That's also one of the presentation of a rickettsial infection. Of course, meningitis and encephalitis, these things which has been well known in that. So these are the some of the things what we need to be as a clinician whenever there is a case of a stroke or the sixth nerve palsy or acute cerebral ataxia, we need to think about rickettsia is also one of the things, especially in an endemic area. That is, it has been published in Indian Pediatrics last year itself. And these are the parameters which is almost with the previous study, it is almost similar to that. Let's come to the other rare presentation. Apart from this, what we discussed is the typical presentation of fever, rash with hepatosplenomegaly. We discussed about rickettsia presenting like a PEO, rickettsia presenting like a ARDS, rickettsia presenting like an encephalitis and other neurological complication. Apart from that, what are the other things which can present? So, child just can present with a fever in a OPD. If you observe, most of the time, the moment we talk about Eschar, we all the time we look at it an axilla and the back side. But look at this child. This is one of the child which came from Salem, which was then Eschar was there in the lower eyelid, and that picked up the child. Child was beautifully responded with our doxycycline is the thing, and it can present like a purpura pulmonans. Purpura pulmonans is a very common thing. So whenever previously it used to be rare, but nowadays we see a lot of cases. But luckily for last 3 years we don't see much of this purpura pulmonans cases. These are the old cases. And stroke is one of the clinical presentation of rickettsial infection. We need to be aware. And of course acute cerebral ataxia. And as a clinician in your clinical practice, any fever with rash, if the child coming from endemic area, consider rickettsia as one of the manifestation, and lymphadenopathy, hepatosplenomegaly, these are the some of the things. Pyrexia of unknown origin, it can present like ARDS, multi-organ dysfunction, acute cerebral and sixth nerve palsy. So what are the clues in the history? The child ailing from an endemic area, consider rickettsia as a thing. Rash involving the palms and soles. Dengue, chikungunya, measles, congenital syphilis, these are some of the clinical conditions where the rash can present with involves the palms and soles. That's the time we need to be. If there is a tick exposure or bite or eschar, capillary leakage or reticular endothelial cell involvement in the lab wise, if there is anemia, leukopenia or leukocytosis, thrombocytopenia, hypoalbuminemia or liver enzyme, rise CRP, these are some of the clues to think about a rickettsial infection. So of course, clinical Rathi scoring system, we have already been discussed. What is more important, immunofluorescence assay is the thing, but it is not available. What we do is CART test for wheel pelix, that is unreliable, and IgM per ELISA, that is relatively, which is, yes, you can make it available in, at least in a medical college level, where you can use it as a diagnostic purpose. Treatment, as far as the treatment of a rickettsial infection is concerned, doxycycline is the drug of choice. 3 to 4 milligram per kg, maximum of 100 milligram BD. Doxycycline, we need to use it. Some of the drugs we can consider is azithromycin and chloramphenicol. We don't, previously we used to use it in almost decade back, we used to use all these trial. But after the experience, so doxy, still it is a good drug. There is no resistance to the doxycycline. So doxy is the drug of choice. The question which has been arises in the clinical practice, can we use the doxycycline in less than 8 years? Because we all read it in my pharmacology, it should not be used in less than 8 years. But since we are using it in a short course therapy, even if you use it in a newborn, nothing will happen. There is no enamel staining and all is noted with the doxycycline. Still doxycycline is the safe drug to be used for a short course of 5 to 7 days. Absolutely there is no adverse effect with the doxycycline is concerned. Before ending my presentation, let's raise some of the few questions, which is what futuristic way we need to be looked in. So rickettsial fever is a re-emerging disease. It is going to be the entity in our clinical practice. We need to accept that because of human behavioral changes, unplanned urbanization, deforestation, rapid transport that leading on to the lot of displacement of the vector, where as a pediatrician, so we need to be aware, yes, it is going to be the entity, it is going to be endemic. We need to consider rickettsia as one of the clinical. And endemicity is one of the most important thing we need to be. That's what we basically, we rely on our patients which is coming from which area it is coming from. When you look at this one, it is Karnataka, Andhra Pradesh and Telangana. Those are the data which has been published and which has been seen, which is there in Indian pediatrics. So these are the areas where we have mapped it. So once you know where the child is coming from, what are the diseases which are prevalent, even I told you, I read it as an undergraduate. I did not read as a postgraduate, but I started seeing as a faculty when I was there in Indira Gandhi. That's how our medical education needs to be. You need to be highly vigilant on what the diseases pattern which is occurring. What we read may not be that relevant in the present. We need to update ourselves on all the things. Is the drug resistance is a reality or a myth? As far as when you look at in the review of a literature, so there is no drug resistance, even though there are few studies mentions about doxycycline drug resistance to the rickettsial fever. Doxy is still a drug of choice, not much of a drug resistance. So at the moment I can say it is not in a reality, but if you use an irrationally doxycycline, yes, it is going to be the reality. That's why rational use of an antibiotic is the key. As a clinician, we need to be. And can the rickettsial become a bioweapon? Answer is yes. Yes, it can be. Reason being, some of the rickettsial agents can be relatively easy to mass production. Their deployment is very easy, releasing just unwinding the stabilized aerosol form or releasing into the infected arthropod. That can affect. That's why it can be a bioweapon. And especially Prowazaki and Rickettsia and type A and Burnetti, all these could be readily used as a biological weapon. More important, Sushumushi is one of the things which is where the drug resistance, some of the report has been reported. This is the one thing that can be used as a bioweapon. We need to be aware whenever the situation arises. So the carry-home message out of this is be vigilant on varied clinical presentation of a rickettsial infection, not just fever, rash, hepatosplagally. It can present like anything during the endemicity. So lot of clinical variation can be there. As a clinician, we need to be aware about that. Endemic region knowledge is a very, very important key. And history of a travel and epidemiological background helps us to diagnosing a thing. Typical clinical for future with a positive clinical examination and laboratory things which can be very, very useful. These are some of the carry-home message. Once again, I thank you, our IAP Twin City branch, especially Dr. Sugunakar Reddy, Dr. NL Sridhar, Dr. RSV Sri Krishna, and all the members of our IAP Twin City for inviting me to this important, and more importantly, our Professor PV Gopala Krishna and family for this. And of course, whatever my infectious disease knowledge is mainly acquired from a great institute of Indira Gandhi Institute of Child Health, where I am working almost more than 2 decades with Professor Shivanand, Dr. M. Govindraj, and all with their experience, what I am today. Thanks to them and also my family members sparing the lot of time to almost spending a majority of the time in Indian pediatrics. Thank you very much. Thank you, IAP Telangana.
Like and subscribe Eagle Media Works.